Hey, maybe we don't know as much about Narcan as we originally thought. If it's Monday, it's magic. Hey, everybody, welcome back to the Monday Afternoon Journal Club. Ed Bowder and Dan Schwester with you today, and we're going to talk about a new study that came out last week about the empiric use of Narcan. Danny, what do we got today?
This is a really interesting study because we've commonly, naloxone is one of those things that we were doing it in cardiac arrest and we got out of doing it because there was a reason for it. This study shows maybe empiric dosing of naloxone in cardiac arrests might actually have a survival benefit. So it's pretty interesting, and it's literally piping hot off the presses.
And this is something that came out on the 20th. So I'm going to bring this up on the screen here. This is coming out of JAMA. And really what they looked at was the empiric administration of naloxone in cardiac arrest out in California. Something that I thought was really interesting was the N of this study is almost 8,200 patients, and it covered 3 counties in Northern California. So in case we're wondering how populated Northern California is. But Danny, what do we got here? What are we looking at?
So basically what we had was they took about 8,200 patients. They did a retrospective study going back a few years. They used Utstein definitions, and they went through the CARES registry, which is already a good data set. They looked at patients who had received Narcan as opposed to patients who didn't receive Narcan, and they saw a survival benefit for the patients that did get Narcan. There's a couple different reasons that we could get into in the paper. One of the interesting ones was the idea of the occult opioid caused at a hospital cardiac arrest. This is somebody that may have overdosed on opioids and we don't know it, or the clues are just not there. So patients who they looked at that. They also found some interesting things. They hypothesized that what I thought was really cool was that naloxone actually may spur release of catecholamines by suppressing endogenous opioids in your body already. The endorphins, the things that you already have in you, get suppressed, causes a catecholamine release, could contribute to higher mean arterial pressures, better response to resuscitation.
And of course, the study, the population that they were looking at, I think, tends to be younger, which is, I mean, that's kind of, I guess, what we would anticipate from a population that overdoses on opiates. So
the median age was about 65. That's not that young, but again, it's not that old. Their cardiac arrest victims tended to be younger and more male than female. But I think it's a pretty good representation. And anytime you get almost 8,200 people in a study, I think your end's pretty good right now.
And the study was looking at whether or not naloxone was associated with improved outcomes. And this is one of those, we joked before we came on air talking about, like what is old is new again.
Mm-hmm.
And it wasn't that long ago that, we were empirically giving naloxone in cardiac arrest as part of unconscious protocol. So it's interesting to see, all right, here's a data set that shows that doing what we did 20 years ago actually has some sort of survival benefit and potentially improves the patients. And it's interesting, I think, to hear that kind of data and like, well, how come we didn't figure this out 20 years ago? So I tend to think that this is probably a function of, the opiate and the fentanyl crisis. We see a lot more people who take those things. And it's also something to consider that, we haven't thought about adulterants necessarily. Certainly when fentanyl was really popular, and not to say that it's not now, when we were talking about like the heroin supply or the opiate supply, we were talking about, well, these might be adulterated with fentanyl or ketamine or whatever else. So it almost seems like at this point, we'd be better off just empirically giving Narcan because, and as much as you and I hate to say this, like, you never know.
Yeah, I agree. I think, this is kind of the, along that lines, not going to hurt, probably could help, might be worth doing. This is something that should definitely spur discussion with your medical director, your clinical people about it. But, remember when we did this 20 years ago, it was a guess. It was just out of nowhere. We're out of magic. What are we going to do? Let's give them some Narcan and see what happens. And, sometimes you got pulses back and we thought, well, they might have been taking an opioid. What I found interesting here is the idea that it can actually stimulate catecholamine release. I think this is something that really needs to be studied more, obviously. But it's a kind of an interesting hypothesis that if we suppress those endogenous opioid type compounds in your body, and this is giving you a boost to your MAP and a boost to your, to your cardiac output, that could be really interesting. Also kind of makes me think, if I'm thinking about my shocky patients, do I want to give an opioid for pain relief as opposed to something like a ketamine that will not have that opioid effect? We're going to have to study this more, but there's some really interesting possibilities coming out from this.
Well, and again, it kind of fits our hypothesis that all roads lead to ketamine at some point.
Sure.
But in this type of study, so what they're talking about with the catecholamines is you have someone who is, usually it's respiratory depression that will start anything, right? And then we get into, your cardiac arrest patients and all that. So when you have someone who's shocky or who's been in cardiac arrest, they're catecholamine depleted, which is the nidus behind us giving epinephrine in cardiac arrest. So, we're giving these medications, we're giving these treatments because it's the right thing to do, but it very much might be the case that in a setting of cardiac arrest, you actually have, too many endogenous catecholamines that are circulating or endogenous opiates that are circulating. And when you're in a cardiac arrest state, you're obviously hypometabolic. So you're not processing things in your body the way that you typically would be. So giving naloxone, and the reason I'm saying this is I want to establish like the delineation, I guess, between empirically giving naloxone in cardiac arrest and giving it for a purpose. Where, if your patient is, say, whatever, mid-20s, and they're unconscious and they have a history of drug abuse, that's someone that you're going to give Narcan to, right? I don't know that we consider patients over the age of 60 to be someone who might have overdosed. And converse to that, I think that those patients that do receive Narcan and get better, we tend to tell ourselves like, oh, obviously grandma was riding the horse. And and that's how we got to where we are. And that's not necessarily the case. So really what's happening is when we're giving naloxone in this type of setting is we're trying to essentially suppress the natural physiologic response to shock states, to cardiac arrest states, and trying to temporize that cardiac arrest state to be more beneficial to resuscitation. So this is one of those, like, it's, if you sat down academically and you were sitting in front, a whiteboard, and you're drawing out the cascade and doing all that kind of stuff, empirically, it's something that seems to make sense, right? If I generate, this is the actual opioid cascade, this is the catecholamine cascade, this is how they degrade in settings of cardiac arrest or settings of whatever, you can explain that. But it's one of those things, like we see it a lot in data where there'll be a study on a murine model or a mouse model, and it'll show vast improvements in mice. But the problem is that humans are not mice. So when it gets moved to in vivo studies with humans, we don't actually see the same result that we saw in vitro in the lab, right? And I wonder if this is one of those things where at a very basic physiologic point, it makes sense, but we've considered using naloxone for exogenous overdoses, that maybe focusing on that for too long or focusing on that too much might have actually negatively skewed our opinion toward giving naloxone. So it might be that this medication, as part of an unconscious cocktail, as part of a cardiac arrest cocktail, was right 20 years ago, but we were right for the wrong reasons.
Yeah, definitely. And remember, nobody's studying this stuff. And 20 years ago, we didn't
Yeah, well,
study
that's the other
anything.
thing. Like studying Narcan,
It was
2024.
it was very cookbook. Those days it was very protocol driven, very very cookbook, very algorithmic. Not a lot of that free thinking. That on the spot making decisions because you have a hunch. Um, I think this is really interesting. I think this is maybe we were right. We didn't know why we were right. It definitely needs to be studied further, needs to be replicated, obviously. But it's a heck of a good start, and it's enough that my next cardiac arrest, I'm probably going to talk to my doc and be like, hey, can I just throw a milligram or two of Narcan into this and see what happens? I don't think anybody's going to countermand that or say no. I think it's probably worth a shot. I mean, if it's that or pronouncing a patient, what do you have to lose?
And operationally, what is the concern, right? So if I'm giving Narcan in an unconscious state, right, or like again, like let's say a cardiac arrest, right? I'm giving Narcan because I want to try and block whatever mu receptors have been occupied, which has decreased the respiratory rate, right? So I give Narcan and it starts the respiratory drive again, right? And now I'm able to breathe for them. The patient is successfully resuscitated. Now I'm going to have to knock them down and intubate them. So I think for a long time, there was also probably a resistance to giving naloxone in a setting where you might have to RSI somebody because of the concern that, well, if I give Narcan, then all of their mu receptors are going to be occupied, which means that I can't give any pain management, which is also not particularly correct, right? With the availability of medications that we have now, and one of the arguments is always like, for RSI, you have to have pain management. Wholeheartedly agree, 100%. Intubation is a painful process. I don't know that we think about, hey, I'm going to go ahead and stick this metal blade into your gullet and then rearrange your anatomy to put a tube in there. I think we tend to be kind of glib about that. And so we have all this concern where, okay, well, I can't give this because it might cause that. Again, devotees of the show will know that I stand ketamine. That is my drug. Ketamine's my boy. But the thing is, with ketamine in this type of setting, I've given naloxone and now I've blocked the mu receptors. And the fun part about ketamine is ketamine acts on the NMDA receptors. So, you'd end up having this sedative and analgesic effect without occupying those mu receptors. So again, looking back 20 years ago when, ketamine was verboten because, it's ketamine, they can't give them special K. Now that we've kind of added that to what I think is the generally accepted algorithm, the generally accepted protocol, it kind of eliminates that problem, right? So now I have someone who's an arrest that I'm not sure what the causative factor of that arrest was. Giving naloxone, and again, we're not suggesting giving 20 milligrams of naloxone. That's entirely too much. But a milligram, 2 milligrams, if you want to make the argument that the BLS that carries the 4 milligram intranasal, you know what? Fine. Only about 25% of that is going to absorb into the serum anyway. So fine. But now that we've given this and we're worried about how we're going to sedate the patient and give them pain management later on, we spent so long only having opiates available to us for pain management, and people are so scared of their own shadow for giving ketamine, it causes this downstream problem where we have patients that probably aren't having the best outcomes they could have. So now we know that ketamine is an acceptable drug. We know that it works. We know that it reduces pain and causes sedation, which is the whole point. So if you're looking at how to go through your cardiac arrest algorithm, or even just your standard unconscious algorithm, given this data, giving empiric Narcan, I think, just kind of makes sense, right? Where, all right, we're going to give this and maybe it works, maybe it doesn't. 2 milligrams of naloxone is generally benign if the patient doesn't have any opiates in their system. That said, please don't give 16 milligrams. Please don't give 20 milligrams. Like that's too much. But all right, we have to start this cardiac arrest, right? Or our patient's unconscious, we have to fix them. If it's not their blood sugar, just give Narcan, right? If the Narcan doesn't work, great, go down to your other treatment algorithm. This is, by the way, this is the only medication, naloxone, where we consider it like a monolith as far as treatment protocols are concerned, right? If I have someone who I suspect is a diabetic and I take their blood sugar and it's not their blood sugar, there's 3 other algorithms I can go down, right? And it feels like if I give naloxone, then there's only like the naloxone, protocol or algorithm, whatever, that I'm under. And I feel like we handcuff ourselves sometimes doing that.
Yeah, I think so. And I want to go back to what you said about, the scared of giving other meds. I think it's a lack of familiarity. I don't know if it's fear so much. I think ketamine is pretty much out there for most places. And the places that don't have it, I think, are pretty much getting ready to get it soon, looking at you, Pennsylvania. But for the most part, we're very comfortable with our opioids. We've grown up with them. We know how they work. We know how we do them. It's one of the first meds you learn about. We give it fairly frequently. I give it a lot more often than I give ketamine for pain because it's first line. It's really easy. It's quick. It lasts. It does good things. All that stuff, right? But here is where you have to think a little, right? And this is where, we have to consider maybe going from another side of the issue or attacking this from the flank as opposed to the frontal assault with your opioids. Ketamine will give you the same results. It will give you good pain relief. It will give you it will give you sedation. It will, if you have to, it will dissociate them. It will do a lot of different things. And, my advice to everybody is, hey, get familiar with it. If you're not familiar with it or you're not comfortable with using it or how it's working, listen, you could go to plenty of places on the internet. Just Google it. There are tons of sites out there. There are tons of things that talk about ketamine, and there's really no reason in this day and age, especially if, as I think we're going to find, we might be able to replicate this data, and it turns out that giving naloxone is something that's beneficial in cardiac arrest. That's a good thing.
And please, if you're going to search ketamine on the internet, please add a tag for like EMS or medicine. Please don't put in the Overrun told me to look about ketamine on the internet. But no, I think that's right. Come back with a warrant. So what do we think for this, Danny? This at the end of the day, are we thinking this is practice changing? We think this is just interesting new information?
It might change my practice. I will definitely look twice at my next cardiac arrest. I will consider it. It's something I may have a discussion with my medical control physician over. Again, not a lot of risk, potentially a pretty good reward. Yeah, I could say that. I mean, the jury's out, but I think this is potentially very practice changing.
Yeah, I think that's probably right. Again, with something like naloxone, I'm not very worried about empirically giving 2 milligrams IV. I do think that again, it's a risk reward cost benefit kind of thing, right? I'm not convinced that I'm going to cause a lot of damage by giving 2 milligrams of naloxone compared to the benefit that I might get out of, giving this unconscious patient a medication that may actually turn them around. And I feel like with a data set like this, it's much less guesswork. It doesn't have the same feeling as like, throwing a bunch of stuff against the wall and hoping that something sticks. But yeah, that I think that's about right. I think we're probably looking at something where this might change some things. If you're in a protocol-driven system where you don't have naloxone and you're on conscious or cardiac arrest protocol, talk to your medical director. Show them this study. Again, this is out of the JAMA Open Network. This is by Dillon et al. And this came out August 20th of 2024. So this is brandy new. Tell them you heard about it on the Overrun on Monday Afternoon Journal Club, because if it's Monday, It is magic, people. Also, check out our new website, overrunems.com, and we still have a bunch of podcasts and videos for you. Check out our news stories on ems1.com, and then check out all of the other things we have to offer you on YouTube and podcasts for the Monday Afternoon Journal Club, Ed Bowder and Dan Schwester. And we will talk to you all next week. Stay safe.